patient comes to the pain, generalized pain, type of pain because of peritonitis. And there could be the abdominal distension and weight loss. Patients say that I have a distension of abdomen or I lost my weight with the altered bowel habit. So upper GI, there is xerostomia, that means dry mouth. Somebody comes with a water bath and there is excessive saliva and all. Amylopania also, they say that, and that is water bath, and painful lips, tongue and mouth because of ulceration, because of an infection, or maybe any infection in the mouth region. Sometimes patient comes with even fungal infection, candidiasis. Patient comes with the pain in the mouth, oral candidiasis. That is, we can see in the immunocompromised patient, HIV patient, or maybe any patient taking oral inhaling corticosteroid inhaler. COPD patient taking the inhaler steroid and not washing their mouth frequently, they lower the immunity of that part of the oral part. Then they get the candidiasis and the oral candidiasis and the painful mouth that they cannot eat anything because it's so painful. Dysgeusia, order taste sensation, dysphagia, that is difficulty in swallowing. Globus, patient feels something lump in their throat. And odonophagia, that is pain on swallowing. Heartburn, definitely patient who comes with burning sensation in epigastric region. Malagastric bakocha, I got the burning sensation in epigastric region. They lead to external region, they say that. But always that is not acid because of acidity. That could be sometime because of myocardial infarction. Flatulence, dyspepsia, okay, early satiety, premature fullness on the eating, and nausea, feeling of the sick with the inclination to the vomit, nauseatic condition, and hematemesis, or vomiting out of the fresh blood, hiccup, and some person comes with the lower GI symptom like wean, excessive and offensive flatulence or bloating, distension of abdomen, and altered bowel habit, diarrhea, constipation. Steatorrhea is the fatty stool, and hematochezia, that is rectal bleeding, and melena is black tarry stool, and jaundice and icterus. So what the symptoms have? Anorexia, definitely we know that a patient doesn't like to feel eat, so there is loss of appetite. Weight loss, definitely there will be the marginal weight loss in between. Some people having GI cancer or carcinoma or tuberculosis, abdominal tuberculosis, patient loses weight very rapidly, and there is a lean and thin people. They say that I was all right a couple of months back, but now I lost a lot. Heavily, I lost my weight and I don't like to eat, and even rise of temperature and so. Then you have to think about that also. And heartburn and all the reflux symptoms, that is because of acidity problem, reflux diseases. And dysphagia, there is so many this reason for the dysphagia, and we can see there's common cause of the dysphagia are oral or painful mouth ulcer. Somebody is having aphthous ulcer or ulcer in the tongue, ulcerated condition, then they cannot eat. And sometimes they have a mouth or throat infection like quinsy, glandular fever, pharyngitis, tonsillitis, those all leads they cannot eat. So that condition also described as a dysphagia because cannot eat. And neurological, so CVA, that is stroke, because of stroke also patient cannot that part is paralyzed, so they cannot swallow the things, they cannot eat. They prevent to eat because they cannot swallow. Whenever they try to swallow, there is a difficulty in swallowing, so they get reflex and cough, so they don't want to eat. Sometimes even cough reflex is absent, gag reflex is absent, so they cannot swallow well, so they don't like to eat solid food, so they go for a small fraction of food or a liquid. And bulbar or pseudobulbar palsy, neurological, that is also, and neuromuscular achalasia cardia, ganglion is lost because of that, natural motility is decreased because of that also, a person cannot swallow. And pharyngeal pouch, sometimes there is a pouch in the pharynx, and that is because of that also, that is obstructing mechanically, so they cannot swallow. And because of myasthenia gravis disease, they cannot swallow, that is also. And a mechanical is there esophageal cancer, peptic stricture, because of also reflux disease, there is a stricture of the esophagus, because of that also they cannot swallow. And esophageal cancer, definitely because of the cancer, there is a growth, a stricture, ulceration, the patient patient cannot swallow that one, and all the compression due to the lung cancer and systemic sclerosis. Those are the common causes for the dysphagia. And causes of the upper GI bleeding. So patient also comes with a GI bleeding, but so we should notice that it is GI bleeding, or sometimes what happens, hemoptysis, patient coughed out blood with a sputum, that is that belongs to the respiratory pathology. So we have to distinguish it between hemoptysis and hematemesis. If it is hematemesis, definitely bleeding from the GI system, then what could be the cause for those things is that one is gastric ulcer, another is duodenal ulcer because of ulceration. There is a breakage of the vessels, and there is bleeding, and because of the bleeding, later on irritation, by the irritation of blood, they can vomit out blood. So esophageogastric varices are there because of alcoholic patient develops the varices, variceal bleeding are there, and variceal bleeding is huge and heavy bleed. Sometimes it's very difficult to resuscitate the patient, and patient collapse because of hypovolemic condition. And biliary steer is what because of repeatedly vomiting, there is a tear of the small blood vasculatures, venules, and there is at last first vomiting is clear, second vomiting is clear, later on repeatedly there is a vomiting, and at last there is a blood in the vomiting. That condition is called biliary steer. That is somewhat less dangerous than variceal bleeding. Variceal bleeding is huge bleed. Then profuse nosebleed. What happens is bleeding from the nose, but patient slowly take all the blood to the stomach, and later on they get irritation in the stomach and they vomit out. And that also we think that that is hematemesis, but we should be very clear that is the source of origin of the bleeding is the nose, and because of nose, patient pinch their nose, they swallow all the blood whatever coming. So later on, because of the irritation of the blood, the patient got vomited out. And oesophagitis, gastritis, and duodenitis, and oesophageal and gastric cancers also gives the hematemesis. And vascular malformation, definitely because of the malformation there is chance of bleeding more. And non-elementary cause of vomiting. So vomiting is always maybe the GI system related, but there is a other cause of vomiting also. There patient, if there is a ICP raised because of brain tumor, or because of blood in the brain, so because of that also trauma and bleeding, and because of that also there is a rise ICP and patient vomits. And middle ear disorder like labyrinthitis and middle ear infection, patient gets vomit. And migraine, definitely in the migraine there is a pain, particular type of pain repeatedly rhythmically repeating in the life, and the patient knows about that also. We should take the history, and there's a flash of light, nausea. The associated with the chocolate is lots of chocolate taking, and associated with the travel, long. This all and more it is we see in the female preponderance is more. So if the female is having with the pain in sometime whole of the head, some part of the head they have a headache, and there is a nausea, there is a so terrible pain, they can see in the light, bright light is hampering, and sudden small tension is aggravating the pain, then this is migraine. Even that condition patient gets vomiting. The severe pain like a myocardial infarction and renal colic, patient even a severe infection, renal colic and myocardial pain, patient gets the vomiting. And drugs like alcohol, opioids, and theophylline, digoxin, cytotoxic agents, and serotonin, those drug also cause, any drug can cause the vomiting. And metabolic causes, pregnancy, definitely in a pregnancy patient patient is nauseatic and there is a vomiting are there. And diabetes, in diabetes, uremia, hypercalcemia, and addiction disease. And a psychological condition also, anorexic nervosa, patient avoid to eat. So they are so lean and thin. They are so much afraid to eat, and they don't eat. If they eat also, they self-induced vomiting is there. So because that is their bulimia. People eat lots and lots. Whenever there is a psychological upset, patient likes to eat lots and lot, and later on because of heavy distance on the abdomen, they self-induced vomiting is there, or they vomit themselves. Rumination, and that also eating, and this is also psychological condition. They think and they ruminify, like one thing they put in their mind and play with that all. That is psychological problem. And abdominal pain, and another complaint is what patient comes with abdominal pain. So I'm not going to describe this all, but there is a certain disease like peptic ulcer, biliary colic, acute pancreatitis, and renal colic. This all gives abdominal pain. Peptic ulcer is all right. It is the region is in epigastric region. There is a stomach is there, and biliary colic definitely that is also epigastric region, as well as right hypochondrium, because it is lies close to the liver. So where is liver? Liver is in right hypochondriac region. So there is a pain, and acute pancreatitis definitely epigastric and left hypochondriac region, and renal colic loin, because kidney reside in the loin side of the part of the body. So pain differs. So among these all, acute pancreatitis is the definitely very much severe condition. We need to resuscitate patient or admit patient in a hospital to look after this, how patient, what will be the consequences of this condition to the patient. Otherwise, peptic ulcer definitely we give the anti-ulcer drug or anti-proton pump inhibitor or any sucralfil like things to heal that ulcerative area. And biliary colic definitely we get subside by giving a medicine and all. And renal colic definitely patient have a terrible pain because of the migratory spiky stone, and we relieve the pain, and later on we decide that patient. But acute pancreatitis condition is more severe among these all. But there is history of either in acute pancreatitis, there is a history of alcohol eating, heavy eating, alcohol, trauma, fall. Those are the things leads to that things. Or there is a stone in the common bind locked, or there because of that blockage, it gives the back pressure to the pancreas, and there is a pancreatitis condition. So non-elementary cause of abdominal pain, there is abdominal pain because of other things also, like MI. Patient with the myocardial infarction comes with epigastric pain, but that is more severe, and patient feelings of impending death. Or enemy is impending death. Patient feels that so much terrified because of that heavy chest pain. It's not the sharp pain, it's a dull pain, like it's a dull pain. Patient is feeling the death is nearby, so patient is so much afraid, and hypotension is there, and cardiac arrhythmia, because some part of heart is not working well. So there we can see cardiac arrhythmia. In ECG there could be the ST elevation, ST depression, something like that. So in T inversion of in ECG, so we need to be very careful about that. Or if there is suspicion of the MI, then we need not to forget to send the cardiac enzymes, and we need to do the echocardiography also, right? And another condition is dissecting aortic aneurysm. That is also very terrible pain. The pain, tearing pain, very intense pain, and the patient say that the pain went to the interscapular pain, tearing pain, interscapular pain, and the hypotension, arrhythmia, same thing. Femoral pulses are not there. Asymmetry of femoral and carotid pulse, and that we can find out. We need to do the CT scan for this, so we cannot see through the. It's very difficult through the X-ray and all. CT is easy to distinguish this condition. And acute vertebral collapse, another that is different. That is the bone condition, and that lateralized pain restricting movement. Patient cannot move. There is tenderness over the involved vertebra, cord compressions, and pleurisy chest pain. And because of pneumonia, also patient can get the abdominal pain if it is in the basal region. Lower zone pneumonia. If there is a lower zone pneumonia, that patient also complain of pain in abdomen. So we need to be careful about that. All herpes zoster, or because of the herpes also patient have but there is definitive there is skin eruptions, like vesicular eruptions, and the pattern of the disease is there is a peculiar type of pattern. Postganglionic pattern type of things, we can see that one. So we need to examine the patient, right? And diabetic ketoacidosis, that's a cramp-like and vomiting, air hunger, tachycardia, and ketotic breath, and patient has a history of diabetes and all. So that has to distinguish. And another is torsion of the testes or salpingitis and tubular pregnancy, ectopic pregnancy. We need to do abdominal scan for that one. So this abdominal distension, there is another thing. Patient comes with the abdominal distension. Common cause for the abdominal distension, normal causes also are there, like a fat. Fat is normal in the obese patient. Flatus, there is air. sometimes it is in bowel obstruction, sometimes because just people have a flatus or more air in their abdomen, and feces, and in constipation or in obstruction, fluid in ascites. This photo is ascitic patient. This patient could be the alcoholic, and there is ascites. One of the cause for the ascites is alcohol, and alcoholic patient has the liver failure, and there is a more distension abdomen like this. This is so shiny, distended, huge abdomen, globular, and this is ascites. And because of fetus also, in a pregnant, if the pregnant lady is there, that her abdomen is distended because of the fetus, not because of any pathology. And another is functional bloating. Functional abdominal bloating also we can see in irritable bowel syndrome. And causes of ascites, definitely hepatic cirrhosis with a portal hypertension, intra-abdominal malignancy with a peritoneal spread. More common is hepatic cirrhosis, means portal hypertension, all related to liver. Hello, who is this one? Who is this one? Please, you open your door and closing the door. Please, you just mute your mic. Who is talking? This one. Either you close up your mic or I close up my class. So intra-abdominal, okay, you don't like to study, it's all right, but you don't disturb. Intra-abdominal malignancy with the peritoneal spread. And less common is nephrotic syndrome, right heart failure, and constrictive pericarditis. Rare but carry syndrome, that is hepatic venous occlusion and tuberculosis, peritonitis, and hypoproteinemia, like protein losing enteropathy. Protein is not there. Protein bounds your every fluid inside vessels. When there is a hypoproteinemia condition, that leads to the definitely what happens? Oncotic pressure is decreased. Because of that, all fluids go into the third space area, all goes into the abdomen. So altered bowel habit. So another complaint, patient comes with altered bowel habit. Sometimes patient comes with the constipation. Constipation could be because of just less of fiber diet. In old age patient also, whenever mostly pain abdomen with the old age patient above 70 or 80 years of age, there's impacted stool because they take very less fibrous food, and they take very less food, as well as they take very less amount of water. Because of that, all in emergency department, old patient comes with the constipation and pain abdomen. That is also the cause for the pain abdomen. So whenever old patient comes, we look first we ask about the bowel habit. What is there? Regular is not there. Since how many days he is not passing stool and all. So another is irritable bowel syndrome. Another is intestinal obstruction and metabolic endocrine. Even in hypothyroidism or hypercalcemic condition, patient comes with the constipation. And drug, definitely any drug of abuser are there who uses opioids regularly. Before, people used to get cough syrup with the opioids. Now it is banned by the Nepalese government, but they used to have lots of opioids, and there used to be history of constipation. And iron, any lady, a pregnant lady having iron, tend to get a constipation. So another is immobility, stroke, Parkinson's disease, and cause of the diarrhea. And this is for the constipation. If patient comes with the cause of the complaint of diarrhea, then there could be a cause. What could be the causes are like infective gastroenteritis, drug, especially antibiotic. Even patient penicillin group of drugs, it gives you the motility, right? So any patient is having like ampicillin, like kind of medicine, then they are bound to get frequency of stool, loose stool. And another is chronic irritable bowel syndrome. Hello, who is this disturbing every time? What ठीक नहीं है? You mute your mic. Then another is chronic irritable bowel syndrome, inflammatory bowel diseases, malabsorption, colorectal cancer, autoimmune neuropathy, especially in diabetes mellitus. There is a neuropathy, nephropathy, all this. Because of that, also patient doesn't feel pain pain during trauma. So they get the leg foot ulcer, diabetic foot ulcer. Because why? Because there is a neuropathy. Same neuropathy happens in this condition also. So patient gets the diarrhea and all, the loose stool, laxative abuse. Some people have bound to have a laxative to for their stool, and later on they are so much habitual to that, so they keep on taking that medicine. And drug therapy, hyperthyroidism, and post bowel resection, if there is any carcinoma in the stomach and all, if there is resection or part of the use part of the bowel or the stomach, then those patients also transient period so less, and there is a frequency of stool, loose stool is there. And post bowel resection and fecal infection, after fecal infection later on they get the frequency of stool, as well as infestation with Giardia lamblia. Okay, now cause of the fresh rectal bleeding. Okay, we talk about the hematemesis, that is vomiting out of the blood, but patient comes with the complaint of the bleeding in the blood in stool or fresh bleeding also. In that condition, we take history of hemorrhoids. Could be there could be the piles. People say in a normal way there's a piles, that is hemorrhoids, or anal fissure, could be the colorectal polyp or colorectal cancer. So any advanced age people comes with the bleeding blood in stool, and there is no hemorrhage and anal fissure, we go for the colonoscopy, because there could be the cancerous condition, or maybe there is inflammatory bowel disease or ischemic colitis, could be any Crohn's disease or ulcerative colitis and all. We need to do the colonoscopy for that. And vascular malformation, massive upper gastrointestinal bleeding. Also, if there is a massive huge, it opens up the pylorus of the stomach, and it comes down, and even it comes with a stool. But there should be very huge bleeding. Upper gastrointestinal bleeding should be very huge. So there is rectal bleeding also. So aortic enteric fistula and endometriosis in rectum. Sometimes what happens? The part of the uterus is comes in the rectum or the other part. Sometimes some people have in that tissue in the nose also, and during the menstruation time they get the epistaxis as well as rectal bleeding, as well as bleeding from the other part of the body. That is that tissue, so that uterine tissue remains other part of the body also. So other cause is jaundice. So people come to the jaundice, then there is a icterus yellow discoloration of face as this way, and icteric this way. Then where there is a increased biliary production. One common cause is hemolysis due to the hemolysis RBC or congenital Gilbert syndrome, or hepatocellular like viral hepatitis, cirrhosis, drug, or tubular hepatitis. Intrahepatic cholestasis, drug, this all extrahepatic, and gallstone, and cancer, and pancreas, and cholangiocarcinoma. Those are. I'm running out of time, so I'm going. Please don't disturb me. Feature of chronic liver disease. What happens if a patient comes with a chronic liver disease? How we can find out this patient? That's the first thing is hepatomegaly. But sometimes what happens? There is no hepatomegaly because of cirrhosis. Cirrhotic patients sometimes, okay, first in macronodular cirrhosis, there is hepatomegaly, later micronodular cirrhosis or shrinkage of the liver, then we cannot find out there is no hepatomegaly. But patient comes with jaundice, ascites, distension of abdomen and all, circulatory changes like spider telangiectasis, there's a superficial vessel dilatation, and this like this, palmar erythema, red hand, it's okay, palm is red, all, so palmar erythema. Some that comes with the endocrine changes like loss of the libido and hair loss, axillary pubic hair, axillary hair loss is there, and a main gynecomastia. So you see that this breast look like a female breast, and there is testicular atrophy because of the estrogen hormone, impotence, and in a woman breast atrophy, irregular means is amenorrhea, as well as hemorrhagic tendency, bruises, purpura, epistaxis, menorrhagia is very common in this kind of patient. And the portal hypertension is splenomegaly, definitely. Collateral vessels, varicose bleeding, and foetor hepaticus is the dead corpse like smell from their mouth, foetor hepaticus. So there could be the collateral vessels like caput medici, I'll show you later on. And hepatic encephalopathy, patient comes with that one, mental clouding, cannot judge or disoriented with time, place, and portion, and other features like pigmentation, digital clubbing of the hand, and leukonychia. It looks very white. There's a nail doesn't look, because nail bed is highly vascularized. We can see the vessel, the pink here. We see the patient is anemic or not in the nail bed, but this patient with the chronic liver disease comes with the leukonychia is whitish look. It's okay, low grade fever. And there is, okay, I'm not going to talk much about this. This is venous engorgement in a superficial venous engorgement of the abdomen, and patient comes with caput medici here because of blockage of inferior vena cava. So whenever abdominal examination, we examine for teeth, tongue, buccal mucosa, and cheek and mouth, and also in detail and that all. And we should smell for the, could be the alcohol, for alcoholic patient, uremic condition, melena, and ketone bodies because of diabetes, diabetic acidosis. and we expose the patient and look fully how the abdomen looks. In normally is slightly scaphoid and symmetrical, both sides equal. Skin, we should see any skin bruises and anything or telangiectasia. So, and visible veins like this, and capitomedusae is here. Snake-like head is called capitomedusae, and that is Bursaceae or something like that. They use that that sign. That is capitomedusae, and capitomedusae means lots of snake in their head. That is things. Okay, abdominal swelling. We so look for the ascites, intestinal obstruction, as well as urinary retention could be that could be leading to the abdomen distension, as well as any other organ enlargement like liver, spleen, and all. So we look for the shape of the abdomen, then flank full or not, movement of the abdominal wall, umbilicus. We see there is any changes, pulsation visible or not, peristalsis movement visible or not. In a thin build people, in a GI gastrointestinal obstruction, we can see peristalsis movement also. And venous prominence, already we saw the photo like venous prominence, engorgement, striae, scar, and pigmentation. On the side we see the inguinal, umbilical, and paraumbilical region, is there is any swelling or not, and appearing and disappearing swelling. Standing up there is a swelling, but lying down there is a disappearing swelling, could be seen in inguinal and all, any localized swelling. So, okay, palpation, we normally we warm our hand, and a clean hand should be there, and we ask the patient and show where his pain is. Then we start from outside and go to that tender part, and we look in the patient face to find out any discomfort or not, and then we palpate away on the side of the pain, and slowly, if there is a mass, then we try to find out this mass is either this superficial or deep. We ask patient to tense their abdomen. If it is superficial, it is more pronounced and more remarkable. If it is intra-abdominal, it disappears because of abdomen is tense. So any swelling, to find out intra-abdominal, we need to relax abdomen or decide whether the enlarged abdominal organ is separate from the solid organ or not. So palpation, there is the two-way. Superficial, we see the temperature and tenderness. If there is inflammation, infection, they say this looks very hot, warm and tender, and consistency or normal or not, elasticity of abdomen. Then if there is a mass, we look for, we note that size, shapes, size, shape, tenderness, surface, consistency, mobility, ages, and attachment. And we measure the abdominal girth, and we do the fluid thrill. This is a patient hand. We put here is a fluid, and we put our one hand in here, and we tap from this side. We can feel the fluid thrill over here. In this condition, in a huge ascites condition. So this is how to examine the fluid thrill. This is abdominal girth. And deep liver, we palpate liver and spleen whenever we are palpating the abdomen, and then we start palpating in the right iliac fossa. From this side, here is the right iliac fossa. We do difference in the 9th quadrant. Then using radial border of the right hand, do not dig in your finger, because it gives the false impression that liver edge is there. We don't dip. Our finger, we press our full hand and try to find out that one. Keep your hand stationary and ask patient to take the deep breath. So keep your hand over there and ask patient to deep breath, and then whenever patient take the deep breath, the liver comes down and touches your hand, and move your hand progressively further up abdomen in centimeter wise. Go up and up and up whenever you find that the edge of the organ. Then if you find the organ, then all need to see size, liver span, texture, surface, edges, consistency, and tenderness, and pulsation is there or not. So gallbladder Murphy sign. What is Murphy sign? Murphy sign is just you palpate in right hypochondriac region, and ask patient to take a deep breath. And while taking deep breath, there is a catch in height of inspiration. Means what? They take a deep breath, but they hold their breath because they feel pain. Inflamed gallbladder comes down during inspiration, and that hits your hand. Patient feels pain, and they stop taking breath. They stop taking breath. In height of inspiration, there is a catch that is called Murphy sign. So we can see in inflamed gallbladder cholecystitis. In condition of cholecystitis, this is positive in most of the patient. And spleen is Again, same way, spleen right hand start with right iliac fossa. Then we ask patient to breathe deeply. Then we just progressively by 1 to 2 centimeter we go up and we find that organ. If it is difficult to find out, and that way, then if spleen is not palpable, then we ask patient to what, palpate with the right hand using your left hand, and we ask patient to turn down, turn to this side. I'll show you in the picture, and in that also another is hooking method. Whenever you are posted in the emergency department, I'll show you how to palpate and how to do the hooking method and all. So aorta, place your 4 fingers and thumb one on another side of the midline in epicastrum and pace down firmly until a pulsation is felt. I'll show you the picture for that also. Rebound tenderness is just press and leave. When a patient gets more pain during the jerk, leaving, because the inflamed appendix is moved in that way, or the other part of the intestine touches the inflamed appendix, so it's more pronounced in appendicitis. So rebound tenderness is more pronounced in appendicitis. When you press and leave because of that jerk, the inflamed appendix hits the other part of the intestine, and they feel more pain. Percussion in general node is tympanic. General node is tympanic and in abdomen. So upper lower border of spleen and all we percuss. And shifting dullness, I'll show you in the picture. Okay, no need. This is how we do percussion in the this is right hypocortic region. He's doing. There is a liver palpation. Here is liver palpation. Yeah, from here right iliac fossa went up, and is going up. So next is okay. This is spleen. How does one hand is here, one hand is here, right hand is in this side, and then from right iliac fossa you start and go up, and left hand is here. You push from here and you ask patient to take a deep breath, and with the breath it moves. Then you can find out this one. If it is difficult to find out in this method, and ask patient to turn to your side and this in a right lateral position, and you can find out that organ. So causes of the hepatomegaly, I'm not going to talk much. Alcoholic liver disease is first one, then hepatic steatosis. This is what is fatty liver, and autoimmune hepatitis and viral hepatitis and primary biliary cirrhosis and malignancy definitely. On other hematological disorders like lymphoma, leukemia, and it's all given in your book. I'm don't waste my time here. And the causes of splenomegaly, lymphoma, and lymphatic leukemias. Okay. And hemolytic anemia, congenital spherocytosis, blood disorder, lymphomas, all sickle cell anemia and all, and polycythemia rubra vera. Hematological disorder gives the splenomegaly. Because why? Because after 120 days, your RBC is coming to die in spleen itself. Spleen is a graveyard of RBCs. So whenever there is a problem with the blood column, and there is a splenomegaly, or because of portal hypertension, or any infection can cause, like malaria, kala jar, bacterial endocarditis, brucellosis, tuberculosis, and salmonellosis. Even in this gives the hepatosplenomegaly sometimes. And rheumatological condition like rheumatoid arthritis, SLE, those sarcoidosis, amyloidosis also gives splenomegaly. So, okay, I'm not going to talk about this because there's a limited time. Later on you come to know about this, because this is a disease: acute appendicitis, perforated peptic ulcer, acute pancreatitis, rupture aortic aneurysm, and this all patient comes in the sick condition, intestinal obstruction and all. There is a polycypin distension of pain. There is a history of surgical scar, because if patient goes in a surgical surgery previously, and now comes with the fullness and the distension of abdomen, constipation and all, and then all visible peristalsis first. Peristalsis try to open up that obstruction later on, and it subsides, and there is no peristalsis, and there is no bowel sound. First bowel sound is increased, later on there is no bowel sound. This all is to lead to intestinal obstruction and all. So rupture ectopic pregnancy, people are there is a history of menopause, then there is a pain, bleeding per vagina, and the patient comes with a UPT positive, but if you do the scan, uterine part is uterus is empty, and that fetal part is seen in a tube, either of the tube. Then this is and there is a bleeding. There's a rupture ectopic pregnancy. This is a really severe condition. You need to look this all, and immediately you have to take patient to the OT. Okay, no need to this and no need to this. So, okay, auscultation, we do auscultation for vowel sounds and like aorta over brute, we show brute vowel sound, normal vowel sound, and we look for the brute over the aorta and then venous hum. And general examination of groin region, we look for hydrocele or phimosis, and this phimosis how we operate and open up this phimosis. And some they cannot pass the urine because it is totally closed. Sometimes a small baby comes with a ballooning of this tip of the penis because this opening is so narrow or adhesive that they cannot pass urine outside. So examination rectum and anal canal we do, and this is a this is the fluid trial, and this is how we find out the abdominal aorta. We palpate abdomen. This is shifting dullness. First patient is supine. We do the percussion from here, tympanic dull, tympanic dull. When we make a patient in right lateral position, and earlier we mark here it was dull, but now all fluid shifted to this side, and this is tympanic, this is dull, this is shifting dullness. Okay, indication for rectal examination. We do rectal examination monthly to find out is there any pathology in rectum or cancer condition or rectum, or maybe BPS, benign prostatic hypertrophy in the male in that condition. Otherwise, nowadays we do the rectal examination, but there is a colonoscopy and all advancement is there, so we're not doing frequently. We do in OPD, but we send our patient for the colonoscopy and all. This is the way to do the rectal examination. Here, and then so hernial part, we get umbilical hernia here, inguinal hernia, femoral hernia, lots of hernia. Sometimes epigastric hernia also we get here, and some patient comes with the hiatus hernia, that is inside hiatus hernia. We cannot see from outside. We can find out the endoscopy also. So investigation. Now we are going to investigation. We have only 10 minutes. 10 to 11 minutes, and it's investigation. What do we do? Investigation is definitely we go. There is any problem, we do stool examination, and we do the fecal occult blood. Is there any hemorrhage, GI hemorrhage and bleeding? Is there or not? To find out that one, we do occult blood, and we don't do this nowadays. We are not doing frequently. This is fecal calprotectin because this is inflamed bowel disease. We do urine because of urine infection also, because of cystitis also, UTI also. Patient have a pain in the abdomen, and definitely we like to see that. And we look for the other things also. In a female, we look for the PID also. Sometimes pelvic inflammatory disease also gives pain abdomen. Definitely ascitic fluid tapping we do if any patient comes with the ascitis, distension of abdomen, alcoholic. If there is a fever, pain abdomen with the distension of the abdomen, then we take the fluid from the abdomen and we send for a diagnostic tapping. We say that we send for the examination. If it is clear and straw color, this is normal. But if there is a blood stain, there could be the malignancy, chances is very high. And then we later on go for the CT scan of abdomen. If it is turbid, definitely there is infection. Then chylus is lymphatic obstruction, high protein inflammatory malignancy, low protein cirrhosis or portal hypertension. Then we do the chest X-ray to any suspect any acute abdomen or suspected perforation discus. We do the chest X-ray, and that time we compare both sides of the diaphragm also, because even pneumonia gives the lower abdominal pain. I already said here is pneumonia. How pneumonia gives pain to abdomen, you might be puzzling, but if that is in the lower zone of the lower zone, then it gives pain to the abdomen also. And we want to compare both sides of the diaphragm. If it is air under the diaphragm in the right side, then there is a perforation. Left side, it is just because of fundic gas. There's a gas in abdomen, gives air shadow in the left side of the chest, but left side of the below diaphragm. But if there is air in the right side, in standing position taken that X-ray, and there is air in below right hypochondrium, below the diaphragm, then there could be the perforation and all. An abdominal X-ray is the same thing. Intestinal obstruction, we want to see if there is any obstruction. We want to see the air fluid level. If it is more than 3, then we suspect that there could be the obstruction, because air and fluid level. I didn't put the X-ray here, but I'll show you the next time. Whenever you come to the ER, I'll show you. and the fluid level is same thing, and other stone also we can see, but not acidic stone. We can see the basic stone. If it is the stack on stone, basic stone, then we can see acidic stone like cystine stone, oxalate stone, urate stone is very difficult to see in X-ray. And barium meal we don't rarely we do nowadays, because there is a gastroscopy is there. We do the gastroscopy. Small bowel follow through. We do subacute small bowel obstruction. Now what do we do the MRI, CT, colonography or CT abdomen. This distinguishes every problems, because CT, if it is not that any obstructive jaundice and acute and chronic pancreatitis, then we do MRCP. Okay. Pelvic ultrasound to find the pelvic for the pelvic masses, inflammatory diseases, ectopic pregnancy, and polycystic ovarian syndrome, pelvic obstruction, abnormalities, ascites, and fluid. Invasive procedure, other upper gastrointestinal endoscopy. We do endoscopy for dysphagia, definitely dyspepsia, GI bleeding. Maybe we want to see the is it varicose bleeding or not. If it is varicose bleeding, we do the clipping also. And that time itself, we clip that part of the varicose. We saw. So there is no further bleeding. Even in emergency condition, if any patient comes with the UGI bleed and it is a varicose bleeding, if hemoglobin permits, if it is less than 6 or 5, we don't go for the varicose banding. But if it allows is more than 10 and there is a blood in a backup, then we go for bending. We bind that part of the varicose part, so there is no further bleeding in a future. Okay, and we do that emergency endoscopy for the varicose blending and malabsorption, gastric, anything. So we do the endoscopy, and that is that we do, and that is a colonoscopy. Definitely rectal bleeding, obscure gastrointestinal bleeding. Is there any bleeding, alter bowel habit, and all? So if we suspect any CA problem or polyps, or could be the Crohn's disease, or we suspect if ulcerative colitis, then we go for the colonoscopy. If old age patient comes with a PR bleeding, then we definitely recommend them to go through the colonoscopy. The pancreatic jaundice, already we saw that. We talked about this all, acute and chronic pancreatitis, and many therapeutic roles, stenting and structure and removing the stones, and laparoscopy, suspect appendicitis or ectopic pregnancy, or that. In all cause that kind of cases, we should go for the laparoscopy. That's the operative procedure. This is, we open up and see if there is any problem. We directly see through our eyes and do the needful. And rupture ovarian cyst, any peritoneal, definitely, or any bleeding or perforation or anything, we just have to do the laparoscopy and laparotomy or laparoscopic surgery. Any perforation is there or any problem is there, any laparoscopic surgery also done nowadays. And then ultrasound, CT guided aspiration cytology and biopsy. If we think this is malignancy, then what we do, CT guided aspiration cytology or biopsy, and we send that that part for histopathology to find out what is this. And pancreatic function test we do for pancreas. And here is, so what we talked earlier is, okay, this is abdominal fundic gas. This is in abdomen. This is a gastric gas. So your stomach is here, and this is stomach air. This is normal, but this is not normal. If it is in right side, okay, then this what this is. This is air in abdomen, means there is perforation somewhere. So we should suspect that. We should ask about the history, ulcerative ulcer. There is could be the ulcer, gastritis, any kind of these things, or appendicitis, or any distension of abdomen, and then there is peritonitis, and there is hard abdomen is not soft, hard, rigidity is there, guarding and rigidity. And if you do the X-ray, and if you find this kind of X-ray, then there is perforation. Take this patient to OT. And this one is obstruction. Definitely there is obstruction of the intestine, huge intestine. Obstruction is seen here. This is intestine. This is the large intestine obstruction. This is okay. Now this endoscopy done here for ulcerative, for varices, for ulceration, and okay, you know how come this? Wait, just a minute. Okay, this is a USG ultrasonography, definitely gallbladder and liver and all ultrasonography, and ERCP looks this way, how they do. And this is the capsule endoscopy. This give the capsule. If endoscopy and colonoscopy could not find any pathology, then nowadays we do capsule endoscopy. Capsule endoscopy, they swallow the capsule and it takes all the picture, and tomorrow we take out that capsule and we just put in and see the what it has taken the picture in all the part of this. So we have done, we have sent one patient, Madhav Gimire, to Delhi because he was having some bleeding from rectal bleeding, but could not find out what is the reason. When he was alive, we sent him to Delhi, and Delhi they have done the capsule endoscopy for him. So this is available nowadays. And this is, of course, CT scan. This is MRI. This is ERCP. Okay. This is MRI again. Thank you. Okay, I'm on time. So, hello. Hello.
Sir.
Yes, sir.
So I finished my GI system today. So I was quite in a hurry because it's so lengthy topic. It's very difficult to finish in one sitting, but they have given us that time to finish in one sitting, only like that. So you all went through. You came to know. Okay, I try to explain how much I can, how much it is possible. So whenever you have any problem, so you can meet me or you can write me in Viber or something or WhatsApp, and you can clear any points if there is any doubt. And after maybe push Mag, I think I'm joining again, and you can just give me a call before the day before you are coming. So you just say that, okay, in the group you can come in 2, 3, or 5, whatever you like, and you just come and say, sir, okay, we have a problem in this, so can you explain this on all? So my class is over for this term. I think there is a 4th term. I think there is a class. I think soon they will give me a schedule. And there is neuro and reprototic. Neuro is very, very lengthy topic. How can I complete within a one sitting, within a 1 hour? I don't know, but I will try my best. But neuro, okay, we go through any problem. Whenever you have, you can come to the hospital, or you can give me a call before a day, and you can take a class itself. Even in an emergency department, there is a classroom. So if you come, I can teach you there. I can show you in a monitor everything, and the patient. Okay, definitely patient will be there. We can go and see the patient also. Whenever you feel that, you feel free to ask about that. Okay, thank you. See you next time.
Thank you, sir.
How many is attendance? Please tell me. Just I write. I cannot take picture of that. What is the attendance?
71, sir.
71.
71.
70.
Yes, sir.
70. Okay. Thank you, then. Have a nice time.
Thank you,
Good
sir.
night. Okay, good night. I'm just discontinuing.